Dr. Maureen Owiti is the head of reproductive health at the Kenyatta National Hospital. On this Health Friday conversation, remember every Friday we have a conversation on health and health matters, and we invite various experts to talk to us about this. Today we want to talk about contraceptives, myths and misconceptions about what? No?
Conception.
Well. Misconceptions on conception. Daktari, good morning.
Morning, Eric. How are you?
Very well, thank you. Karibu sana to Kenya's biggest conversation.
Thank you very much.
Siti, please give the Daktari the day's proverb.
Yes, this is our final proverb from the country of Congo Republic. He who is free of fault will never die.
He who is free of fault will never die.
Yes.
Dr. Owiti, what's your interpretation of this?
That one's easier than the last one. I think the only person who's free of fault is obviously our Maker, who never dies.
Kwisha.
That one is so conclusive. You don't even dare add anything to it.
Yeah, Kwisha.
Just say thank you.
Kwisha. So we want to talk about contraceptives. First of all, just to be clear, what is it that we call contraceptives?
Okay, we have modern contraceptives and we have traditional contraceptives. So I think it's a story that has gone back in time, biblical times. There was the proverbial, was he called Onam or something like that? Huh? Yes, who...
Onan.
Onan.
Onan, yes, thank you for correcting that slight error. So anyway, his brother's wife had passed on. So his brother had passed on, and I think like Africans, I think everyone is African. It's just how far you traveled from Africa.
Quite right.
That made you change. So they inherit, I think, just like I think I'm Luo, so we have that tradition. Fortunately, we don't practice it anymore, I hope.
We do.
Okay, my family doesn't. So, so he inherited. Yeah,
Onan's brother died.
Yes, so he inherited the wife, and he was supposed to have produced seed so that his brother's lineage could continue. But he decided to pour his seed, as they call it, outside. Now, I think the Catholic Church used that as a sign that we're not supposed to have contraception. But the issue was that he was using it for his own sexual pleasure. That's why God punished him, because of using it for his own sexual pleasure, but not necessarily for contraception. So we call that withdrawal method. And this is something a lot of people, especially older women, are able to use quite efficiently, but it's not as effective as what we call the modern day contraceptives. We'll move from the withdrawal. We have people count their days, what we call the fertility awareness. So you have women, if you have a regular cycle, maybe we'll count your days. We have some special fertility beads that you're able to use to count. Some women know the secretions they have from the vagina when you have the change. Some people measure their temperature, what we call a basal body temperature. And they all do all that to find out when they're ovulating and avoid intercourse around the time of ovulation, so they don't conceive. So also not a bad method, but again, not as effective as what we'd say modern day contraceptives. So when you go to modern day contraceptives, either using a pill or a device or have had a procedure to achieve your goal. And goal can be spacing. So if you're talking to the people of community, Somali community, they don't like the word contraception, but they're very open when you tell them that you're just spacing the children. So you're doing the birth spacing so that the mother is not having your step ladder, 1, 2, 3, kila mwaka. So we start with things like the barrier methods. Yeah. So barrier methods are condoms, and condoms come for both male and female. And the advantage of barrier methods, unlike any other method, they also protect you against sexually transmitted infections. And I think the people in that space, the HIV space, have done such a good job that everyone thinks a condom is for preventing HIV/AIDS. They forget that a condom is actually a contraceptive. If you ask everybody, they know it's a condom.
Primarily, that's what it is.
Primarily, that's what it is.
Okay.
So if you go then up the ladder, we have hormones. So we have progesterone and we have estrogen, which estrogen normally is used in conjunction with progesterone. So we'll call that a combined method. And we have progesterone-only methods. And those can come in the form of injections, pills, implants, and they help the woman achieve their goal, which is either to space or not to have children at all. From there, we move on to things like the most effective methods are, say, the implant, which is a progesterone-only method. It's a subcutaneous implant that is put under the skin. So subcutaneous means under the skin, okay? And they can stay for various amounts of times. The implants we have is either a single rod that will last for about 3 years or a double rod that will last for about 5 years, but a woman can remove them at any time. You put it today, you're not happy with the method, I can take it out the next day. Okay. Then we have the IUD, that's an intrauterine contraceptive device. Layman, we call it the coil. So it's just a tiny, tiny, tiny device, the size about a matchstick, that we put inside the uterus.
Matchstick is not tiny.
Okay, I think terms are relative. Okay. But it's not so big also. Okay. So we put it inside the uterus and the woman is able to have it, I think the longest is about 10 years. And she'll achieve contraception for the duration the device is in. And then we have what we call the permanent methods. Okay. And in the permanent methods, we have two. At least men, I don't know why, we only have the male condom and a vasectomy. There was some talk of the male pill, but in usual fashion, in your talkily.
So what is siasa? Let's stick. You've told us about the permanent ones. That's where you're heading. Men. You said? Which one?
It's called a vasectomy, Eric.
Okay. And for women?
For men, we call it the bilateral tubal ligation. So these are permanent methods. And
what does permanent mean?
So permanent means that once you initiate the method, okay, it's lifelong. It's lifelong. Vis-a-vis, like for example, the implant or a condom, it's for the duration that you use it. Once you stop using it, your fertility resumes. So I think you talked about myths, and for me that is the biggest myth about contraceptives, that there's a period you need to wash off the hormones before your fertility returns. I think it's just people not really understanding fertility. Any reversible or non-permanent method, the moment you remove or stop using the device, your fertility resumes immediately. Okay. Now, it's understanding that even people who have never used contraception, so say you're a married couple or you're a couple in a consensual relationship and you're having regular intercourse, so regular intercourse would be at least 3 times per week and not Friday, Saturday, Sunday. That's 3 times, maybe on alternate days, something like that.
That's not regular.
It's regular, but would not achieve because you have a window of 4 days. And if you ovulated during that window of 4 days, you're not going to be pregnant. So physiology of pregnancy is you need to have sperm in the reproductive tract around the time of ovulation. And the woman ovulates once in a month, and it's 24 hours. That egg is alive. You either make it or miss it. No, there's no otherwise, okay?
There's a 24-hour window in a month.
Yes.
All
okay.
right.
So it's either you make it or miss it.
So people who manage to have that step-by-step arrangement of children, so it means they figured these cycles well, or they have a hell of a lot of sex.
I think alternate day is reasonable. Now, what you also have to remember is sperm deposited in the reproductive tract will stay alive for about 72 hours. So there's that overlap. Okay, so we say a couple, if the woman is under 35 years of age, we can give them up to a year, and it's normal for them not to conceive. Okay, but beyond a year,
why is it normal?
It's not a must. It's not a must to be pregnant because you're sexually active, and as I've said, that window is 24 hours, and also sometimes people are pregnant, but we have what we call chemical pregnancies. Okay, so she miscarries around the time of her due date. She just thinks it's a delayed period. It could have been a miscarriage. We don't know because we don't check hormones every month to see whether the woman is pregnant. So we normally give them up to a year, and that's within reason. So if, for me, somebody was on a contraceptive and they conceive 9, 10, 11, 12 months post-removal of contraception, it was not that there was a delay because of the contraceptive device. It's just the normal physiology of pregnancy. Okay. So I think that's the biggest myth, and I hope I have clearly demystified that one.
They were, what's the word? You said when you remove it,
your fertility resumes immediately. Yes.
Okay. So despite the delay, your fertility was back to normal immediately.
Yes.
You removed the device, or you stopped the method.
It's understanding. Maybe somebody had an STI and their tubes were blocked. Okay, so it's not because of the contraceptive that they're not conceiving. They're not conceiving because they have another issue that happened while they were on the device.
Okay.
Okay.
Can we talk a little bit about, it could be called a myth or it could be called a truth, but emergency contraception is seen as a way to, stop pregnancy, but then used regularly could be an issue here. And we know, for example, that girls between the age of 15 and 20 are using emergency contraception regularly as a normal contraceptive. Okay, where are the dangers here?
Thank you very much, Ndu. You must understand with the e-pill, we have much, much higher doses of hormones than we have in the regular combined pill or the progesterone-only pills. So she's getting supranormal levels of progesterone and on a regular basis. So the e-pill is exactly that. It's an emergency pill. So your condom burst. You had the misfortune of having a sexual assault. That's the reason we should be using an emergency pill. Pills are readily available over the counter, and sorry to say that maybe 200 shillings is not that expensive, but I'm being sensitive that for some people it could be a heave. And I see their dispensers with condoms all over the place. So I think it's just we need to educate the public that you need to use some other form of contraceptives rather than taking the e-pill. It messes your cycle and can cause other severe effects, and we really don't want that to happen. So,
why does it do that? Why would it mess your cycle?
The level of hormones in it is very, very high. Okay. So it's not good for the woman to take on a regular type.
What is regular here?
Okay, it's like if you look at pharmacies, weekends.
Yes. Let's start with Friday, shall we?
Yeah. Friday to Monday
morning. Weekend inaanza furahi day.
Okay.
So how many times would you advise somebody to use an e-pill in, let's say, in a year, in a span of 1 year?
For me, I would not advise somebody to use an e-pill unless they have an emergency situation. So it must be an emergency situation. Otherwise, we have so many forms of contraception available. You feel you don't want to be pregnant, please, you have your healthcare center just around the corner. And at the healthcare centers, the services are very affordable and you're able to get yourself a form of modern contraception rather than taking an e-pill.
But so you agree that there is some abuse of this?
Definitely.
Should it be regulated? Should it now stop being over the counter, or should there be some?
With those ones of you're caught between a rock and a very, very hard place. Would I prefer women are able to access the e-pill when they need it, or they get pregnant and you want to start having the conversation of, do we terminate this pregnancy because I don't want it? So for me, I'm clear the lesser evil would be let them get the e-pill.
But you see, you can introduce some step here in mandating the dispensing person to have a conversation before dispensing, so that you create more awareness. For example, you say, have you taken this in the last X number of days? Are you really sure that this is an emergency?
I think
and
that's
this and the other before dispensing.
dispensed, yeah.
Because people walk in and walk out like, you just went there to buy chalk.
Sweets.
Yeah.
Yeah, I think that's a fantastic conversation, and I think it's something that as the healthcare community, we could think about how to support so that actually this is done, and not just on the e-pill. There are many horrible things happening, and I think the first is, if I look at, I've seen insurance companies are mandating pharmacies to be a point of care for minor ailments, and I think that's wrong, and the pharmacies should actually reject this emphatically, and say, because you don't know, somebody comes that I have an itch, a rash somewhere, is the pharmacy going to examine someone's private parts? No, it could be the starting of cancer, and she's being given drugs for a fungal infection. I think it's actually criminal what is happening. Yeah.
Another myth, a couple of these. So you talk about bilateral tubal ligation as a permanent contraceptive, essentially. Is it possible to get pregnant after having one of those? Secondly, the breastfeeding period by lots of women is sworn to be a natural contraception. Is that true?
Okay, so those are two very interesting questions, too. And so let me tackle the first one. So broadly, it's understanding there's what we call method failure. Okay, and method failure and the method being permanent are two different things. Okay, so in my long years of practice, I have delivered women using all forms and including the bilateral tubal ligation. I have only never delivered a person who their method of contraception is a vasectomy. Okay, so there could be several reasons to that. So normally our caveat is, and I always start by that, I don't know why I didn't start that way, that there is no method that is 100%. Okay? Having had said that, the failure rate, especially like for the long-acting methods, is very low. It's about 0.5%. Okay, so if we're to put that into figures that somebody can concrete, we'll say it's 1 person in 200 users, the method will fail and they can be pregnant. Okay, so for the bilateral tubal ligation, yes, I've delivered women who have had a bilateral tubal ligation and subsequently fallen pregnant. So it's in counseling. We always counsel women prior to initiating a method. You need to stress that there is that possibility. Okay, yes, but if the method hasn't failed, you have 199 women who will be satisfied because the method is going to deliver what they want them to achieve.
This is the one where we talk about tying the tubes, right?
Yes.
Is it reversible in any way?
Okay, so you can reverse. Having had said that the success rates, even a vasectomy can be reversed, but the success rates, wow, that was hard.
Don't worry, that's all right. Success
rates.
Okay, is just about 25%.
Okay.
And
so they have a quarter chance of success.
Yes. Okay, it's possible. But if somebody's had you also need to have very highly skilled surgeons who are familiar with microsurgery, and vascular surgery. So, for me, from the gynecological place in Kenya at the moment, I'm not familiar with anyone who's doing that.
Okay.
But we say it's a tubal issue, and we can bypass that. So, if somebody would want to say conceive after bilateral tubal ligation, one, you'd have to really wonder what happened at the time of counseling, because something wasn't. Some things were not put right. So for me, for a permanent method, I'd ask the woman, you see you have 4 children now and you're very happy, yeah? And you want a tubal ligation. God forbid, should something happen, because it has happened, you see, a family was in a car crash, the mother had gone on job somewhere and her whole family is wiped out. Maybe she remarries and now wants children with a subsequent partner. So I put them in that type of scenarios so that when you're putting it, you're sure 100% that liwe liwalo, I will live with this decision. I am not going to have another child. So, but having had said that, we have ways. So we have the in vitro fertilization. We can bypass the tubes and help the woman conceive.
Okay. Hysterectomy, removing the uterus.
Yes.
Would that be permanent?
A hysterectomy would be permanent, though anecdotally, I have one of my senior colleagues who mentioned that he had a woman who had an ectopic after hysterectomy. I was like, what? And I also had something.
Ectopic to term.
No, it wasn't to term.
Okay.
But she had an ectopic pregnancy, so that's a pregnancy outside, because a pregnancy should be located inside the uterus. The uterus is not there, and she's pregnant, so that's an ectopic pregnancy. So, and I think I also heard something. I read a paper on it in some international journals, so it's something that is possible. However, those are very, very rare circumstances. So a hysterectomy is definitely permanent. However, we don't do a hysterectomy
as a birth control
method. That's a very major operation which needs to be done with a clinical indication for it.
And what would bring that about? What would necessitate it?
Pardon, a hysterectomy?
Yes.
Various things, from cancer, fibroids, especially if like you're bleeding too much, you have symptoms of the fibroids, just any pathology in the uterus that would require that.
Still, the myths around the e-pills are quite a number of issues for that coming from folks.
What are the second question?
There was a second question about if the myth about breastfeeding period being a natural contraceptive.
Okay.
So maybe we can combine that then with the long-term effects of using the e-pill for a prolonged period.
Okay. So in terms of breastfeeding, sorry, I didn't mention it. We call it lactation amenorrhea method. Okay, so this is a woman who has newly delivered. So we say for as long as she is exclusively breastfeeding. So that means the baby is not getting water, not getting any other form of water or nutrition from any other source other than the mother's milk. Okay, so that's what we call exclusive breastfeeding. So that's the first condition. And the second condition is her periods should not have resumed. Okay, so we normally do exclusive breastfeeding for the first 6 months of life. Then from there we start weaning the baby. So if the woman is within that period, her periods have not resumed, then it is a method, and a very good method for contraception. So that is true.
Excuse me.
Teacher.
What if the periods have not resumed?
Yes.
But they're not exclusively breastfeeding? They are breastfeeding.
Yes.
It's just that the baby is also...
Okay. There's a chance of a pregnancy.
How would the body know that the baby is not exclusively feeding from you?
No, but you're the mother. You're the one who feeds the baby.
Yeah. But how does the body know for it to fall pregnant?
Okay.
Because here, what you're saying is, if you are exclusively breastfeeding, that is, you're breastfeeding and the baby is not getting nutrition from anywhere else.
Yes.
And your periods have not resumed.
Yes.
You have lower chances of getting pregnant.
Okay. So it's...
If your periods have not resumed, you are breastfeeding regularly, but the baby is also getting nutrients from elsewhere. Your chances...
Like if they're bottle fed.
Yeah.
Wait.
How does the body know that this baby is not only breastfeeding?
Formula.
Are we saying that this breast milk feeding of baby is also a form of contraception?
Yes.
That's the thing.
Lactation amenorrhea method. So it's understanding how does it work. When you're breastfeeding, Your body releases prolactin. In fact, it's one of the, when somebody's not able to have a baby, it's one of the hormones we check. And when you have high levels of prolactin, we know, oh, this is what's stopping you from having a baby. So by breastfeeding exclusively, you're releasing if sufficient enough levels of prolactin to cause that contraceptive effect. The moment you're not doing exclusive breastfeeding, my guess is the levels are not that high.
Okay.
So there's a possibility of pregnancy.
There's a question that somebody. Oh, how do you answer the
I
second
think it's the
question?
same one about long-term effects. Of,
long-term
the
effects.
e-pill.
Okay. So you find that you're using a lot of progesterone, okay, and it's definitely just going to cause side effects. So if I look at even any woman who's on a progesterone only method, what are some of the side effects? So you find things like hypertension is a possibility. So we have to really monitor how her blood pressure is going, okay, and you find that also, what do you call this thing? As I've said, the levels are just very high. It's causing an imbalance in how your normal hormones are supposed to be working. So it's just going to definitely have some side effects. Yeah.
Someone says in some places TL is denied to women, especially when one presents without their partner or some supposed consent from the partner. Is that legal?
Okay, so I think, Eric, you should be a lawyer and advocate for women. Huh? And it's I think, also part of misinformation and misconception on the part of the service providers. So you find even us as service providers, we come with our own baggage, okay? And it's understanding the woman is autonomous. She's over 18 and this is her body. Having had said that, in this autonomy, she chose to be married, okay? So we try as much as possible to involve the male partner, because you don't want acrimony in their marital home.
Yeah.
Okay? But I tell couples when they come that, fine, we're involving the husband or spouse in this conversation, but primarily I tell her, the decision is yours. And if your husband says he doesn't want you to use this method, okay, the decision, and you feel this is a method you need for you because you know what you are going through, and you consent for it, I have no right to deny you something because your husband has said no. The only issue is, please don't bring for us your domains in the clinical area.
Afterwards.
So you have to look for how you're managing the domestic situation. But we try as much as possible to bring the partners on board. And but we should understand she's autonomous. She's over 18, has a mind of her own, and should be able to make a decision that is good for her.
Okay. Dr. Ari, next time, the road will be clear. The gate will be open.
We'll make sure.
We'll make sure that you get here on time. Thank you very much for joining us.
Thank you so much, Eric. It was
time.
a pleasure. It was really a pleasure.
Karibu tena. Dr. Maureen Owiti, people are calling you Viola Davis. I'm sure you've heard this before. She's been here.
Not the first time.
She's been our guest telling us how to get away with murder. Contraception.
Same thing. Okay.
One. Asante sana.
This is the Situation Room, the only way to start your day.